Hi, this is Tom Oding, University of Iowa. I'm showing an interesting case I did recently with Beth Kutzbach and Chris Watts. This is a 50-year-old woman who had an iris and lens coloboma. And you can see that as we're doing the rhexis, we're initially making the tear away from the good zonules. But as we get over in the area of the coloboma, the rhexis starts to go downhill a bit and goes out radial. You see right there we're stopping. And now we're going to use a little rescue maneuver, and we're going to pull the opposite direction and then towards the center and rescue that tear, which brings it back so that the tear is continuous. During hydrodissection, you can see that we get a nice fluid wave. Initially, we're not really too concerned about the hydrodissection, but more on that later. The nucleus divides into two pieces nicely. You can see now we change the settings to have more vacuum, and it looks like the lens is no longer supported by the capsule, and it's beginning to decenter way too much, and it's clear that the capsule no longer is intact behind this lens. So we keep complete occlusion, pull the lens into the center, place some viscoelastic behind the lens. But let's watch again in slow motion. Watch the area here in the area of the coloboma where it appears that the lens was weak, and you can see that as we do the hydrodissection, that weak area blows out. And now that area blows out even further during phaco. When we put the fluid back on again, you can see that suddenly that area blew out and probably went posterior. So we decided to convert to an extracapsular surgery. We're initially going to use a crescent blade to bring our incision to the limbus, and then we're going to use Castroviejo's corneoscleral scissors initially to the left and then to the right to open this up. We only need to open it up to about 6 or 7 millimeters because this lens is relatively soft. Here we're using a lens loop. We're going to pull out this lens material. We want to follow that with Westcott scissors in case vitreous comes forward. We made a separate incision for our anterior vitrectomy instrument, and we're removing some vitreous. We're pulling some cortical material with a dry technique into the center, and then we're slowing our cut rate down to remove that cortical material and clear the lens of the cortical material, leaving only the bag. We make the decision to place a glued lens in this case. The eye was too small for an AC or an anterior chamber lens, and so we're going to use the Agarwal technique where we use a 20 gauge needle to make an entrance underneath our little scleral pocket. We're using a 26 gauge needle to make the side incisions for the haptics. It's very important to use an anterior chamber maintainer during that process, otherwise you won't be able to get in. Here we're placing a 3-piece acrylic lens. It's an MA50, and we're just going to put it in the sulcus temporarily. And now we're going to use this handshake technique that Agarwal has shown us all, where we use 2 Duet forceps, and we grab this haptic, and we pull the haptic through the tunnel that we made with the 20 gauge needle. Doing the same thing on the other side, 2 Duet micro forceps, and we pull that haptic through the tunnel made with the 20 gauge needle. And now we're going to tuck those haptics into the little tunnel that we made on the side, on both sides. It's helpful to use some dye here so you can find that little hole. And now we're going to place these flaps down, and we're going to use some fibrin glue. Apply it in 2 parts. I think you have a little bit more control if you do it that way. And we're going to make sure that that haptic gets covered. And then we're going to use that same fibrin glue to reapproximate the conjunctiva. And this fibrin glue, every time I use it, it's like magic. It's so beautiful, and it works so well. We pushed the flap over a little bit here because there was a little gap there, just to make sure that we had correctly, completely covered the haptic. And now we're going to bring the conjunctiva over. And this is, of course, after securing that limbal incision. We placed some dilute 10:1 preservative-free kenalog to complete the vitrectomy, make sure there was no vitreous coming forward. We placed some myocol in the eye, and we sutured the larger of the paracenteses. So far, the patient's done well. This is Tom Oding, University of Iowa. Thank you very much.